Okay, hi everybody. How you doing? We're talking about specific phobia today, which some of you might be all too familiar with. So the first thing I want to do is show you a clip of a woman who has a really severe, of a woman who has a very severe snake phobia. Okay. I don't know if this is gonna stop. Here she is. So you can all see a woman at a computer. Okay, good.
Meet 22-year-old Mariam Doom from Venezuela, clinical psychologist Lars Göran Erst from Sweden, and Alf. He's an American corn snake. This multinational threesome is working together. Mariam helps out when Alf gets tangled in Erst's belt loops, and Erst helps Mariam put Alf around her neck. The picture looks simple enough, unless you go back in time, just 3 hours ago, as Mariam was preparing to meet Alf for the first time.
That's what a panic attack looks
Mariam
like.
has a specific
If it's
phobia,
really
a
severe.
fear of snakes. Other specific phobias include claustrophobia and a fear of flying and thunder. Mariam's had almost no contact with snakes and doesn't know why she's afraid.
Since I remember myself, I remember being afraid of snakes.
She has trouble with movies.
I have to close my eyes always.
At the zoo.
It's impossible.
And it interferes with her life.
But I had dreams of snakes. It's horrible. Like I like the scuba dive, and there's snake gills and other snakes.
Mariam is a research technician here at Boston University's Center for Anxiety and Related Disorders. Psychologist David Barlow is director of the center and a pioneer in exposure therapy. His research demonstrates the outstanding success that's been achieved in treating phobias in a very brief time period, just 1 week. Some psychologists at the center use virtual reality to gradually introduce a patient to a feared situation. But Erst bypasses all that. He treats specific phobias in just 3 hours.
What he's done, though, over the years, and he leads, in some way, leads the world in this, is strip the program down to its essence.
Barlow invited Erst from Sweden to demonstrate brief exposure therapy.
In the hopes that we will be better able to apply it here in the United States.
And Mariam has agreed to be treated in front of her colleagues. Exposure therapy requires that patients gain experience with the feared objects.
Unless one is willing to experience one's own negative emotions and expose them as not dangerous and overwhelming or threatening, then they probably will not be able to overcome their anxiety and phobia.
But some say this intense exposure is cruel.
I disagree completely, because everything we do in the treatment is decided by the patient. And it is within this time limit a very gradual approach.
There are surprisingly few people, given the suffering that they have endured up until this point, who aren't willing to take that plunge and see if they can overcome it.
People have this idea that you suddenly pick out the animal and throw it in the lap or the patient. That will never happen.
It's teamwork. First interviews Mariam for 45 minutes and then describes and prepares her for treatment in an additional 15 minutes.
So I will challenge you to try things, but I will never force you to do anything that you're not.
It's critical to determine Mariam's worst fear, what's called her catastrophic belief. Her catastrophic belief is that if a snake is loose and she can't escape, she'll have heart failure.
How certain are you then that you might die as a consequence of that interaction?
Maybe 70%.
70%. Okay.
No one has ever died or become ill either with Ernst or Barlow's treatment, but Mariam believes her anxiety won't diminish and she'll escape.
Like run away from the room.
The strong belief in the catastrophe, that is what's driving the avoidance behavior. And the avoidance behavior is the directly maintaining factor for the phobia.
But if Mariam doesn't escape, Ernst predicts her anxiety
Would then gradually diminish as we go along in the treatment
and importantly, there can be cognitive changes.
to help you get new information about that catastrophic belief.
Ernst does not prepare patients with relaxation or deep breathing.
I don't think it's necessary at all.
We discovered through systematic research evaluating this component that patients receiving these skills, were trained in these skills, who then use them to cope with their anxiety or fear, actually did not do as well.
Deep breathing masks anxiety, and the patient doesn't learn anxiety isn't dangerous. Here, it will be used only if Mariam hyperventilates. Just prior to exposure, she rates her anxiety on a scale of 0 to 100.
70 or 80.
Now, it's time to go get the snake. Mariam's anxiety soars.
I can stand with my back towards you if you want to.
Okay.
And then I
Like
can,
when I close my eyes.
and then I can gradually turn.
No.
Standing here now with my back towards you.
First does that for 2 minutes. What is Mariam thinking?
It was horrible. I felt that I was going to leave the room and that it was, stronger than me.
And what was Ernst thinking about her reaction?
Maybe not the strongest I've seen, but up there among the 25% strongest.
But he knows that initial anxiety is not the best predictor of success. It's motivation to succeed. She lets him turn around after 3 minutes.
Okay, I'm going to close my eyes. Okay, but don't come.
No. Doing good. Let's try to watch it. It's in my hands.
She looks for the first time.
That's the only way you are going to get new knowledge.
Okay.
It's completely peaceful.
She stands and smiles as her anxiety level comes down.
50.
She's learning.
That if you stay exposed to the situation long enough, you see that the anxiety level goes down.
She lets him enter after 8 minutes. She realizes that her catastrophic belief can't occur unless Ernst releases the snake.
I'm not doing that.
After 15 minutes, Ernst sits down. Some anxiety returns.
Try to breathe slowly and calmly and with your stomach.
She calms down.
So, what about the name for it? And where are you going?
I'm going to move here.
Okay. What do you think it feels like?
This is it's a nice snake.
Her anxiety is down.
30, great. You're sitting about, what is this, 3 meters away?
She decides to approach.
Okay, I'm gonna approach her. I'm gonna approach her.
Yeah, good.
But hold it.
Yeah,
What psychological principles might account for the improvement so far?
it might be that you have habituation going on, which leads to extinction of the anxiety reaction. You could say that the confidence is increasing, self-efficacy, Bandura's ideas come into play here. From a cognitive point of view, I think what is happening here is that the patient is, with the help of a therapist, accepting to take in new information.
There's also positive reinforcement and modeling. What's Erst's assessment so far?
Deep in my mind, I know it's going to work. That means that I don't have to be impatient, I can be calm.
Certainly, his research supports his confidence. Across several types of specific phobias, even with children, Erst's research shows over 80% improvement compared with control groups. And the results are maintained at a 1-year follow-up.
Well, the research is actually very, very strong. I must say surprisingly strong when you consider the kind of dramatic nature of the intense approach.
It's close to 1 hour now, and she decides to name the snake.
Maybe Alf.
Alf,
Yeah.
okay. Alf, that's a nice name. What would it feel like touching it?
I'm thinking about it.
Yeah,
After an hour, she touches Alf.
good. Did you touch it?
A little bit.
A little bit, yeah.
I'm not even touching a snake.
You are touching the snake.
Progress is very uneven throughout the afternoon, but it provides an opportunity to challenge the catastrophic belief.
No. And you died.
No.
No, you survived. Great.
Alf is placed on Mariam's lap, but again, progress is uneven. Alf's on her lap now alone.
One more time.
One more time.
And finally, it's time to test Mariam's catastrophic belief. But Alf's more interested in the radiator and warmth.
The snake didn't do a lot of things that she predicted it would do.
What about Mariam's catastrophic belief?
Is it down to 0?
Yes.
Good.
Now it's time to pose
A
Can you,
picture.
can you stand?
and then help untangle Alf. As for her anxiety,
Yeah, and at the end, when I was helping here, it was 0 completely. That impressed me, the last part really, I was able to do that.
there was time for some celebration and congratulations.
Did you really think you'd be able to get this far?
Reflect on the implications for treatment.
We have no reason to believe that the 3-hour program would be any less effective than the 1-week program. So then it becomes an issue of, what would the patient choose? There are many patients who really don't have the time to take a week out of their lives.
The recommendation is that Mariam engage in maintenance, watch nature films, go to the park and the zoo.
Is that if I see a snake on the street, at least I'm gonna be able to see it and walk, and not see it and run.
And 2 months after treatment, we spoke with Mariam by phone.
I have dreams with snakes, but I didn't have any anxiety. I also watch movies with no problem and pictures. So I think that I'm doing great. I really feel confident that if I see a snake, I won't be scared.
Okay. All right, so how long did that treatment take?
Months?
What'd you say, Ryan?
Didn't say 2 months, or was the follow-up 2 months?
The follow-up was 2 months.
Okay.
Wasn't it like just an hour?
Yeah, it was like up to 3 hours, but she didn't take that long. And how severe did he say her reaction was to when she first saw the snake? Does anyone remember how bad he said the reaction was.
Didn't he say like it was probably one of like the worst like reactions he saw?
Yeah, he said it was among the 25% worst, strongest reactions because she was having a panic attack. She was crying. She clearly wanted to flee, right? So that was a pretty strong reaction. What are some of the things that made such a scary experience a little bit easier for her as the patient?
He probably like he exposed her in steps. So first he like turned around with the snake,
Mhm.
and then slowly they got closer, and then she was able to touch him and like name him.
Right. So he did it, like systematic desensitization. It wasn't flooding, right? What would flooding be?
If he just like went and like gave her the snake.
Yeah. He like threw the snake at her, or put her in a snake pit, it's that kind of thing. What was her most catastrophic belief? Anyone?
She was gonna have a heart attack if she saw a snake.
Yeah, she thought the snake would come right at her, right? And then she'd have a heart attack and die, and that she wouldn't be able to escape, right? And how sure was she that she would die in the presence of the snake? Does anybody remember?
It's like 70% sure.
Yeah, she was 70% sure she would die when confronted with the snake. So that's pretty severe, right? But she still signed up for the treatment, right? And people with specific phobias are pretty sure there's going to be a horrible outcome. That's what a catastrophic belief is, that some catastrophe is going to happen. And a lot of behavioral therapy, cognitive behavioral therapy, focuses on examining the catastrophic belief and kind of testing whether it's a realistic one.
What if like someone believes there's a catastrophic something catastrophic will happen, but they don't exactly know what that is?
Yeah, that's like more of a, like a panic attack, but with an unexpected one. Or like, because people have expected panic attacks in the presence of the thing they have a phobia of, right? Not all the time. Not everybody with a phobia has a panic attack every time they see it. But yeah, like a kind of, they could have generalized anxiety disorder, or they could have, panic disorder if it's more kind of something they can't pinpoint, right?
I mean, like, what if like she said like she had a fear of snakes, but she didn't know why she had a fear of snakes?
Like, so if they asked her what's the worst thing that could happen,
Yeah,
and she says, I don't know.
just that she's a
Well, then they
extremely
would
different.
test the catastrophic belief just generally that something horrible would happen. And like nothing horrible happened the whole time she was with the snake. Like it was scary, but nothing terrible happened, right? So, she had a more specific catastrophic belief to test, but, either way, just being in the presence of the thing helped her realize nothing horrible was going to happen, right? So let's see. So he thought, like Erst thought, that just being exposed to the thing that people fear the most helps them learn, just because, and we'll learn that what learning is just experiencing two things close together in time. And somehow she thinks that, snakes and death are gonna, be close together in time. They're gonna come together. And she was in the presence of the thing and nothing terrible happened. So now she associates the snake with nothing horrible, right? And that's learning. Exposure is just learning what comes along with something else, right? So in her exposure to the snake, the longer she was exposed to it, the more clear it became that nothing horrible was going to happen, and her anxiety went down, right? Now, what do you think a drawback of a 3-hour therapy might be? Like, if you can treat a phobia in 3 hours, why does anybody have a phobia? If it could be cured in 3 hours, why is there anyone left on Earth who has one?
Some people probably don't want to be exposed to whatever they're afraid of for 3 hours.
Right, right. So people who people who are certain they're going to die, maybe even people in like the top 15% are like, hell no, right? I think I can hear my husband, so he's going to hear me talk about him, but he's definitely afraid of heights. So yeah, we could get somebody like Ernst and go, to the top of a mountain and like confront his biggest fears, but he won't go. He's just not going to do it. So it's like a lot of treatments, they'd work if you could get someone with that disorder to do it, right? Like the drug antabuse, for people who have a dependence on alcoholism, you take it, and if you do drink alcohol, you feel absolutely horrible. It just mixes with it and creates an interaction whereby people throw up, just feel terrible. Oh, and other ideas for why people don't want to do it. They might not have the time. It's very draining in a short period of time. It could be traumatic. Yeah, all those things. Um, yeah. But because of all those things, the people who have the disorder don't want the treatment, right? The treatment might feel even worse than the illness because the people aren't constantly exposed to snakes or spiders or whatever it is they fear the most. So I was talking about antabuse, and what does somebody do if they're going to have a relapse if they're taking antabuse? They know if they take it, they're going to throw up and get a horrible headache. And
Can't they can refuse to take that, and because they know it's, and I've heard that also too, because we have reason that like if you take it, you kind of, it's the pill that's causing you that, so it's not the alcohol. So doesn't that sometimes have an
yeah,
doesn't
you
that
could
sometimes
be
have
like,
an issue?
well, yeah, you might not associate it so much with illness. You might not learn to associate alcohol with feeling that sick. It might just be a temporary stopgap because you're going to feel horrible if you do it. The research shows that among people who take antabuse regularly, it totally cuts down on alcohol use. Like, people don't use alcohol if they take it. But the key words there are if they take it, right? People with alcohol dependence, if they are feeling really vulnerable and have a relapse and sense it coming up, they'll stop taking the medicine, right? So yeah, there are a lot of treatments that will work great if people will do them, right? Like, I think I've mentioned before that if someone's depressed and they exercise, the depression goes away. But by definition, like, that's what depression is. It makes it hard to get out of bed and take a shower, never mind go work out. Right? So it's a treatment is only as good as how many people you can get to do it, right? So that's one of the drawbacks. But, by the way, the guy who was saying, not Ernst, the other guy, that's Barlow. He's one of the authors of your book. He was saying that a lot of people are willing to do it. They're willing to do the 3-hour treatment. Then again, you know, he works at a center for anxiety disorders, and the people he sees might have already kind of identified themselves as people who want treatment, you know. Does anybody here have a phobia? I mean, you don't have to share it, but does anyone have one they're willing to share? Anybody afraid of spiders? Really like arachnophobia, a bad one? Okay, at least one. Just one. Okay. How about mice? How about flying? One. Okay, how about, let's see, what else? Heights. 1, 2, 3, 4. Yeah, phobias are super common, right? Let's see. What else? What are some common ones you guys can think of?
Claustrophobia.
Huh?
Claustrophobia.
Claustrophobia.
Isn't there like water? It's like water phobia.
Uh-huh. Yep. Swimming. Oh, the tiny little holes. I forgot the name of that. Does anybody have that one? Let me, somebody shared that. Let me look it up. Oh, and I have a little prop just to freak everyone out. Trypophobia. So those pictures of things with little small holes. Hold on, I'll get you something. So things like this. It's a lotus pod. You know, so those lotuses you see in ponds, you know, so this has all little holes in it. And some people are completely, you know, phobic of things with little holes in them. So like a close-up of a strawberry, you know, because it has the little tiny seeds that sit on holes. Haley doesn't seem to like this picture. And it's funny because I got these because I think they're pretty. And some people will come to my house and be scared. Anybody else have trypophobia? Okay. Oh, and there's a really common one is emetophobia. Does anybody know what that one is? E-M-E.
Isn't that the fear of throwing up?
Yes. A lot of people have that one. So it can be, so like as soon as you start feeling a little sick, you're really scared that you might throw up, right? And then there's blood injection injury phobia. Anybody have that, like needles? You know, it's like phobia of needles. And sometimes when there's a unique response in people who have that not every, that the other phobias don't have. Does anybody know what that is? There's a way people respond to that people with other phobias don't. When they're like supposed to have their blood tested or. They have what's, huh?
Oh, sorry about that. Don't they faint sometimes?
Yeah.
When it comes to needles?
Yeah, they pass out. That's why, like, if you're afraid of needles, you know, they ask you usually when you go to get blood taken, they usually ask you, you know, are you okay with needles? Because if you're not, they're going to lay you down so that you don't pass out, you know, and they're going to be super careful. But yeah, it's called a vasovagal response, and people's nervous systems, their sympathetic nervous systems, like go wild. Like at first, the heart rate goes way up, and everything, like the blood pressure and everything goes way up, and then there's like a reaction to like calm down your body, and that's when people pass out. So I think I told you guys my one of my sons had that for a while. Did I tell you about that? A cat, one of our one of our cats scratched his face. It was on Christmas. And so I was just like I was just cleaning it. And I said, I said the wrong thing. I probably like caused the phobia in him. I said, oh, wow, it's so close to your eye. Thank God he didn't get your eye. And then he went and fell backwards. He was like, probably, let's see, he must have been like 9. And so he woke up almost the second he passed out, and he was okay, but I called 911 just to make sure, because he also kind of fell on the floor, and I didn't know if there was an injury. But then the people who responded were firefighters, and they had to put in a central line in him. And they weren't, that's not their specialty. So that added to the blood injection injury phobia. And then he had to go to the ER, and it wasn't a good enough stick, so they had to redo it. So that from there after, every time we went to a doctor's office, or even we went to get his glasses, we went to get his glasses and they adjust them. So anything slightly clinical, he'd be like, can I have some water? And he'd get faint, and then I think I told you guys he had to get a flu shot this year. I didn't tell you guys this? So I was like, are you going to be okay? Because when he had his 12-year-old immunizations, I had to hold him down to have them. And he was like, yeah, why? And I was like, do you remember a year ago I had to hold you down? And he was like, and his twin was like, that was a year ago? Feels like you were like 6 when that happened. And he was like, oh, that was a year ago. I'm like, so are you going to be okay with the flu shot? And he's like, yeah, I'll be fine. And then he went and he was totally fine. So that's why in kids, you have to wait a while before you diagnose someone with a disorder, because they just go through so many phases, so it's hard to distinguish just like a developmental blip from a disorder when they're really young, right? But I'm glad he's not feeling stressed by that anymore. And most of the treatments are the same. Let me go back so you're not distracted. But usually the treatment's like the same. It's like exposure. And I had a student who was an EMT, and he had it. So imagine you're like a first responder who has to deal with injuries, and you have a blood injection injury phobia. Like a lot of times people faint when you're just talking about an injury to them. So he's an EMT and he has this phobia. That's pretty unfortunate. And exposure alone didn't work, right? Because he had more exposure than most people do. And just exposure didn't work. But there's other things people can do. When people have a vasovagal response, they can clench and unclench their muscles so that the pumping of their blood, their circulation doesn't just go way down and they pass out. So one of the things is like crossing your legs at the knees, even if you're standing up, and that helps people not faint. So, yeah. And anyway, it was so funny because like a month before he had to get the flu shot, I had put him in teletherapy because I was worried about his phobia, and he didn't have it anymore. But anyway, it's good for people to be in therapy. So these are the symptoms of specific phobia: extreme irrational fear of a specific object or situation. Like there are some things that make sense to be afraid of, And, you know, it does actually make kind of evolutionary sense to have some of these fears, right? Like, which ones does it make evolutionary? Like, people have fears of clowns, and I don't, you know, there's not like a, you know, there's not like a reason that's existed over thousands of years to be afraid of clowns, right? But some of these there is, right?
Fear of heights.
Huh?
Like a fear of heights.
Yeah. Like people who like walk around on cliffs, you know, on like razor's edge, aren't gonna, you know, on average, more of them die young before they have kids than people who stay off precipitous, you know, cliffs, or, you know, people who take scary pictures of themselves at the Grand Canyon, right? So there's more people in the population who don't do that kind of stuff, because more people die who do that kind of stuff, right? What else? What else does it kind of, in a Darwinian way, make sense to have a fear of?
Like dangerous animals like snakes.
Yeah, like snakes are venomous, a lot of them, you know, so not, I don't know how many, I don't know what proportion, but snakes can be venomous and deadly. So we have, you know, we're evolutionarily programmed to fear them, right? Oh yeah, sorry, snakes, spiders, dangerous animals, right? So it makes sense to be afraid of like mice, spiders, snakes. Why are we afraid of rats and mice in an evolutionary sense? Like, why do
They
we?
spread diseases. They can spread diseases.
Yeah, they spread disease. So, like, in some ways, people who naturally have a fear of this are more likely to live to reproductive age and have kids who will tend to have the same fears, right? That's why it's a common fear. The thing is, in people who have a phobia, it's a thing that's natural and makes sense, but it's over the top. It's in overdrive. It's, you can't turn it off. You know, it's a good thing in a small dose, you know, in an adaptive dose. And then when it's too high a dose, it's not a good thing, right? But for it to be a phobia, you know, the person has to go to great lengths to avoid it. The other thing is, like, if somebody lives in Massachusetts and has lived here their whole lives, it doesn't really make a lot of sense to still be really afraid of snakes. There's no really dangerous snakes here, right? And there's not really a lot of dangerous spiders here. Everybody talks about the brown recluse, you know, but if you go online, like, people post pictures of the spider that bit them, and it's like never a brown recluse. So, but people will go to great lengths to avoid it, like an elevator heights. They'll like walk extra miles to not, you know, and they'll go up 15 flights of stairs to not take an elevator. And most people recognize that they shouldn't be this scared of the thing that they're scared of. But some people don't. And it used to be in the older DSMs, it used to be that um, people had to realize that they shouldn't be this scared to be diagnosed with a phobia. Like, if you were somebody who said, no, actually, that clown is going to kill me, so I'm not going near it. And you said, do you really think that clown is going to kill me? And you said, yes, and I'm right, and it is going to kill me, you'd be diagnosed with something else. What do you think you might get diagnosed with instead of, why would that be different? Why would that be different? Uh-huh.
It's like it's a delusion. Almost.
Yeah, it would be more like a delusion, like somebody who's out of touch with reality. But they've figured out that people who are not psychotic and not delusional sometimes have this kind of compartmentalized, totally irrational fear that has nothing to do with the rest of their mental health. So you can be completely deluded about this one thing and just get diagnosed with a specific phobia and not get diagnosed with any kind of psychotic disorder. And it says markedly interferes with one's ability to function. But say somebody's like markedly, totally terrified of escalators and they don't need to go on an escalator. If it bothered them, I would still diagnose them with it if they wanted to get treated for it, but technically it has to interfere with their functioning. But there are a lot of phobias that don't interfere with people's functioning much, right? I had a student, however, who had a phobia of fruit, all fruit. And so she said she'd go to class and somebody would have a banana on their desk, like right next to her. And she'd be almost having a panic attack and they would have no idea, because who would think, right? So some are going to markedly interfere with functioning no matter what, and some of them are far less disabling. Right?
Are you sharing your screen for the slides?
I'm supposed to be, it doesn't matter that much, but oh, there it is, sorry. Yeah, so these are, the general symptoms of a phobia. Thank you for telling me that they're not up there. You got to see me for a while. Yeah, so most people, but not all, recognize that it's an irrational fear. So these are the DSM's like really specific criteria for specific phobia. It has to last 6 months or more. Okay, so it can't just be that like what if you got bit by a spider and you had to go to the hospital? You might be kind of terrified of spiders for a little while and then you get over it. You wouldn't diagnose that person with a phobia. It has to last a while. The thing provokes immediate fear, and the person either like flees or they stay there with intense anxiety. Right? So some people, out of pride or wanting to fix it, will stay there. And so and it's interesting because they might stay there and still maintain the phobia, even though supposedly it's exposure that is the treatment. So see, the fear or anxiety is out of proportion to the actual danger. So there is danger to heights, there is danger to thunderstorms and lightning, but it's way out of proportion if you're in a safe place. Now, D is where the person can kind of decide whether they have the disorder or not. If the person's not distressed by it, if they don't care that they have this fear, then they don't have to be diagnosed with it, unless it's something like fruit and they can't go to class, or they can't have a relationship with somebody who likes fruit, who they really like, something like that. And it can't be better explained by the symptoms of another disorder, like PTSD, maybe. Like if somebody, like if Daniel, my son, only had that fear because the Christmas Day going to the ER was so traumatic for him, right? And he interpreted it as like he might possibly die. But it's way more clearly a blood injection injury phobia. Okay. Again, like a lot of anxiety disorders, females are overrepresented. So in most of them, there are more females than males who have it. Look how many people in the general population have it. That's why so many of you, well, not that many of you had it. I forgot what there were a lot of you who answered yes to something, but I don't think it was to having a phobia, was it? Anyway, and they tend to be chronic unless people make a real effort to get rid of them, which is not really common because people don't want to be in the presence of the thing they're afraid of, right? So these are the most common ones. Animals, natural environment, situational, blood injection injury. Oh, so not everybody who has the blood injection injury has the fainting response, but many do. So there's a bunch of different ways somebody can get a phobia. Usually somebody has, a genetic predisposition to it, some kind of biological vulnerability. But it could also be that they go through a really intensely stressful situation too, that makes them more vulnerable. If they have several things on the life stress index, like losing a loved one, having to move, being in a war-torn environment, things like that, that can predispose somebody to, even if they don't necessarily have a big genetic history of it in their families. And then they can have a direct experience like my son did, or a vicarious experience, just seeing in a movie or just hearing about how dangerous something is. That causes an alarm reaction in them. And then they just tend to continue that reaction. They just tend to, have the same, increase in heart rate, same increase in respiration every time they see or think of that thing. So sometimes it's learned, sometimes it's biological, sometimes it's a huge stressor makes them more likely to get afraid of things, right? Like think about PTSD, although we haven't covered it yet. But people with PTSD have a heightened alarm response. They have a heightened, an exaggerated startle response. They're just like, they're more likely to jump if they're startled. Right, so think about that. That's gonna like make people more likely to be afraid of something, right? Okay. So direct experience, biological vulnerability, a trauma, preparedness. Some do you know some people who over prepare for things? Oh, well, think about preppers, right? Doesn't that almost kind of does anybody, you guys know what I'm talking about? Preppers, people who like hoard food that you can prepare in the event of a worldwide catastrophe or something like that. So planning for the worst, but in an over the top kind of way. So this whole semester, when I say which psychological treatments work, it's going to be some cognitive behavioral treatment. That's where the best evidence is for pretty much all the disorders. So cognitive behavior therapies are the most effective, and it's always exposure. Like for anxiety or anxiety, similar to anxiety disorders, it's always going to be exposure, exposure, exposure. Go towards the thing you fear. Do the exact thing you don't want to do, which sucks, but it's just the truth, unfortunately. And cultural factors. Certain objects are feared more in different cultures. Like in India, the most common nightmare. Okay, what's a common nightmare here? Sorry, it's 110, but I'll just tell you. The most common nightmare in India is being chased by a stray cow. Okay, has anyone here had that nightmare? It's not like a common one here, but there at least used to be, like in the 90s, 50 million stray cows in India. So apparently they chase people occasionally. I don't know. You're probably more likely to have a nightmare about a dog chasing you, right? So different cultures will kind of shape what you're more afraid of and where you are. Okay, well, we'll stop there. And I'll see you guys next time. Thank you.
Thank you.
Thank you. Have a nice day.
Thank you.
Bye.